So this is a series that we are working on uh, along with the ACCF, that is the Assam Cancer Care Foundation. This Assam Cancer Care Foundation, we are working with them to standardize cancer care in Assam state. And also we are looking at other benefits that the patient may get and the physician may get with the involvement of Navya and the Navya technology. So as a part of this, we are also having webinars which are interactive in nature with the expert panel and on select topics. These webinars will be at a frequency which is around once in month to once in 2 months. And so this is the first webinar. I welcome all the panel of experts, Dr. Bhawna Sirohi, Dr. Rakesh Kapoor and Dr. Shravan Nadkarni. And I welcome all the participants for this webinar. The topic of the today's webinar is multidisciplinary management of rectal cancer. So just to brief you about Navya, Navya is a cancer informatics and patient services company that leverages technology to provide personalized evidence-based cancer treatment plans. So we collect all the data of the patient, that is the diagnostic reports and also the clinical notes, and we run it through our artificial intelligence and machine learning ontology engine, which has the evidence engine, experience engine, and it also considers the patient preferences. And it prepares a structured case summary and also gives next line of treatment if there is any thing that is recorded in these databases. This is a structured summary that we are going to use for discussion of the cases today. Now I request Dr. Bhawna Sirohi to introduce herself to our participants.
Hi, good afternoon, everyone. I am a GI and breast medical oncologist, currently working in Balco Medical Center, Raipur, Chhattisgarh.
Thank you, ma'am. She has given a very brief introduction about herself, but the achievements that she has accomplished are plenty. And like we also just noted only 3 or 4 of them, but there is a big list actually. Thank you, ma'am, for joining us for this webinar. I request Dr. Rakesh Kapoor to introduce himself to the participants. Sir,
Hi.
please.
Good evening, everyone. I'm Dr. Rakesh Kapoor. I am professor in Head Unit 2 in PGI MER Chandigarh. And this is my alma mater. I am a product of PGI and working here. In between, I had 2-3 short stints abroad and one to Tata also as a director of both Homi Baba Cancer Hospitals in Punjab, Sangrur and Mullapur. So I am back to my original alma mater after completing my 2 years there since 1.5 years back. I am looking after GIT, gynae, breast, as well as sometimes in PGI, you have to help all your colleagues, and so I sometimes see sarcomas also. Thank you so much.
Thank you, sir. Thank you for your brief introduction. Again, the amount of contribution that you have made in your field is excellent, and we don't have much space to write about all that. Thank you, sir. Thank you for being on our panel. Now I request Dr. Shravan Nadkarni to introduce himself. Please, sir.
Hi, everyone. I'm Dr. Shravan Nadkarni. I'm a consultant surgical oncologist at a trust hospital in Hubli, Karnataka. It's a DR institute. It's the Karnataka Cancer Therapy and Research Institute. I'm managing all subsites of oncology cases with a special interest in GI oncology. And frankly, it's actually a privilege for me to be a part of this panel with such senior medical and radiation oncologists. I have learned from them, and it's a very big honor for me. Thank you very much for inviting me, especially Navya and Dr. Narashayana. Thank you.
Thank you, sir. Thank you for the introduction. Though you say that you have learned from the other senior doctors, you have joined them on the panel, and your work on the evidence-based care has been excellent, and we keep seeing your work every time. Thank you, sir. Thank you for joining us.
Thank you.
Now I request Christy to present the first case. You want to come?
Hi everyone. Hi everyone. The first case is an early anorectal cancer. The clinical context for the case is the patient is a 60-year-old woman with the stage 1, that is T2N0M0 anorectal cancer. Histology is adenocarcinoma. The patient underwent robotic mobilization of rectum, transanal intersphincteric excision of anorectal growth, and reconstruction of anal canal. The current diagnosis is early anorectal cancer. The patient has no family history of cancer, and the complaint started in July 2023 with hematochezia, diarrhea with mucus. The initial symptoms had started since May 2022, but the patient had ignored it. But as symptoms persisted and frequency of diarrhea has increased, the patient consulted doctor and the diagnostic scans were suggested. The patient underwent a colonoscopy on July 5th of 2023, which showed large anal verge lesion, which was polypoidal and ulcerated. The procedure note showed anal verge mass, which was suggestive of malignancy. Then the patient underwent a colonoscopic biopsy on July 5th, 2023, but there was no evidence of malignancy. Multiple fragments with the features of tubular villus adenoma with a low-grade dysplasia was shown. The patient underwent FDG PET-CT on July 6th of 2023, which showed 3.3 into 1.6 centimeter anorectal wall thickening of SUV 18.9 with a luminal narrowing. No evidence of malignancy elsewhere in the body. Then the patient underwent an excision biopsy from anal canal on July 18th, 2023, which showed no evidence of malignancy. Villus adenoma with a low-grade dysplasia was seen. Then another biopsy was done on the same day from the base of adenoma, but there was no evidence of malignancy. The patient underwent the surgery on August 9th, 2023. The surgery was robotic mobilization of rectum and transanal intersphincteric excision of anorectal growth and reconstruction of anal canal. The operative note showed that tumor was 1 centimeter from anal verge and another polyp at 2 centimeter from the verge. Underwent wide local excision of tumor with the 0.5 centimeter margin. The pathological tumor size was 2 o'clock to 5 o'clock position, and the final margins were negative. Muscularis mucosa infiltration was present. The pathology note showed anorectal tissue with the ulceration, villo-glandular adenomatous lesion showing moderate atypia, and focal areas shows infiltration of glands into muscularis mucosa. Anal mucosa uninvolved and deep muscle fibers uninvolved. Growth of anal canals is suggestive of no evidence of malignancy. Another slide block review was done with the same surgical specimen, which was dated August 21st, 2023, which showed a malignant disease of adenocarcinoma from the anorectal tissue. The cancer grade was 1. IHC was positive for CK7, CK20, and CDX2. Ka67 was 50 to 60%. Pathology note showed SMA highlights muscular layer, P53 null type expression, infiltration up to muscularis propria. Pathological tumor stage was stage 1, PT2 NXMX. Then there is a clinical note from surgical oncology. Final histology shows tumor with the foci of adenocarcinoma. Tumor reaches up to muscularis, but it is not involving it. The base is clear. The final staging is T2N0M0. As per NCCN guidelines of 2023, these are 2 options for T2. A is observation, B chemotherapy with the FOLFOX. The blood workup is not available. The ECOG of the patient is 0 to 1. The patient is able to do activities of daily living without any assistance, no significant disease-related symptoms. The patient wants to know the role of chemotherapy. There are no resource constraints. And the current plan of treating oncologist is either observation or chemotherapy, depending on the patient's choice. Caregiver has also consulted another oncologist who wanted to know the feasibility of lymph node dissection. So this is the first case.
So I think
here I would like to know the inputs
from the panelists. Maybe I can start with Dr. Shravan, because it seems
more of surgical intervention the patient has undergone.
Right. So I see there is.
Sir, you are on mute. You're on mute.
Am I on mute?
no, you're not.
Okay, sorry.
Right. So I see there is quite some discrepancy as far as the initial pathology report and the final that was available. So what I'm understanding now is it is an adenocarcinoma which is invading into the muscularis mucosa. Can you scroll up a little bit? That's fine. That's fine. So tumor reaches up to muscularis. I think that's mucosa, not involving it. So this is definitely a malignancy, and with the imaging being done only as a PET, which is a distant metastatic workup, and now that we are deciding whether to give chemotherapy or to observe the patient, the first thing I would want here is to see the condition of the mesorectum. So if there are any nodes, if there are any mesorectal nodes versus lateral pelvic nodes, although I agree that in such an early lesion, I would not be expecting too many lymph nodes. But the MRI would help me decide as to whether the patient would require a further surgery as far as evaluating the mesorectum and resection is concerned versus observation. These cases are best discussed in a multidisciplinary joint clinic where you have the contributions from the radiologist as well, the medical oncologist and the radiation oncologist. And depending on the MRI findings, I would proceed further.
Yes, sir.
Hello?
Yes, sir. Dr. Rakesh Kapoor, sir, wants to add.
Naga, I think looking at the whole history and the multiplicity of the polyps in this patient, because it is not one polyp. Already 2 polyps have been removed, and you should, first of all, I think we should have a colonoscopy to see whether there is anything higher up or not. Local MRI, I fully agree with Dr. Shravan that a local MRI should be done. But keeping in mind the high Chi index, 50 to 60%, and inadequate lymph node dissection, I will not be in favor of observation in this patient. I will definitely like to give an adjuvant treatment, even if lymph node dissection is not contemplated. Still, adjuvant treatment should be given to this patient. So that is my stake on this, because you can't leave such patients with a high Chi index and those who have multiple polyps there which are infiltrating into the definitely it has infiltrated to the muscularis propria. So if it would have been up to submucosa, or say we could have given a chance there, but now the grade is less, but still going to the muscularis, chances of lymph node involvement later on will be very high. So in anorectum, it is the local disease which once comes, it is very difficult to mitigate later on. So preferably some adjuvant treatment is required at this setting.
Let me just add one thing, sir, here. This is for the benefit of all the audience. So most of the lymphatics in the rectum is into the lamina propria and below. So once the tumor infiltrates through it, going through the muscularis, then the chances of lymph node metastasis exponentially rise. So as sir said, if lymph nodes, the lymph nodes need to be evaluated to have a further plan. As for the colonoscopy, I think the colonoscopy was done, sir, and only the rectal polyps have been mentioned. There's no mention of other polyps. So once that is confirmed, I think we can safely take it as only rectal disease.
I like Dr. Bhawna to comment on this, because she can say better as a medical oncologist than me on this issue.
Thank you. I think Dr. Nadkarni and Dr. Kapoor have brought out very valid points. So this patient actually highlights something which we see in the clinic all the time. You know, we keep on discussing, the patient has had 1 biopsy, 2 biopsy, and I've had patients where they've had 4 biopsies, you know, and it still shows high-grade dysplasia, low-grade dysplasia. And for, at least for me, we need a diagnosis of at least adenocarcinoma or squamous cell carcinoma before we can give chemo or radiation. Very rarely, I would say, where an MRI pelvis has been done, and, you know, we've even done examination under anesthesia. So I think it's very important to do, as has been pointed out, a baseline MRI pelvis. This patient has had an FDG PET scan, which is fine. But ideally, in the same cost, it would be MRI pelvis and a CT chest abdomen would suffice. And this would be done in the same cost of a PET CT. And the MRI pelvis would tell you about the T staging and luckily this patient has T2 disease, which is great. But, if he had extra EMVI or if he had any node involvement, so we need to know that, because low rectal cancer, we may want to give chemoradiation there. So it's very important to try to get the diagnosis pre-op and do proper staging, because that will help you guide the adjuvant decision making as well. So in this patient, they've had no nodal dissection. It's not N0, it is actually NX, because no nodes are seen. And in rectal cancer, of course, there is this debate. The optimal nodal dissection in colorectal is about 12. But in rectum, actually, it's not the number that matters. It's actually your TME planes, the quality of your specimen. The pathologist will tell you, and Dr. Shravan will actually may talk about it more, how to assess the quality of the specimen. So all of those are more important. So I agree that, on erring on the side of caution, we would recommend chemotherapy irrespective of what the NCCN says. Observation is not the way forward here. So what did Navya recommend? I'd love to see that. I actually haven't looked at the cases deliberately because I wanted to do them real time. So lymph node dissection, not separately, it comes out, Dr. Shravan, with the TME specimen, isn't it?
Yeah, so unless there are any lateral pelvic lymph nodes which are more than 7 mm in the pre-therapy image or more than 4 mm in the post-therapy, of course, this patient has not received any radiation. But unless the lateral pelvic space harbors nodes which are malignant looking, then the entire lymph node packet comes out with the specimen. So the TME itself takes out all the mesorectal nodes, and we go up till the IMA as far as removing the entire specimen is concerned. So that takes off the superior rectal nodes and the mesorectal nodes as well. Just a word about, since you mentioned the quality of TME specimen, so the AJCC is pretty elaborate on how to assess the quality of TME specimens. So there is a grading by which we are supposed to see whether there are any breaks in the mesorectum, whether there is any coning, and usually if you have seen the TME specimens, at the levator you can see there is a something like a waist. So that waist should not be there. It's called Morton's waist, and it is where it constricts. So a TME specimen should be cylindrical, is what is the standard.
So, say Dr. Shravan, the MRI does not show any nodes in this patient now, but would you recommend still the option for an observation or to go ahead with chemotherapy, as I was suggesting and Madam has also said so? Because I am looking at the other components which are showing a high risk for local recurrence. So
yeah,
even
with the 60%, yeah, please go on.
Even if now doing a MRI may not show a pelvic lymph nodes or even the mesorectal lymph nodes in a T2 disease, but still looking at the other factors, when the lymph node dissection has totally not been done, and even the higher Chi-67 index, what do you suggest? I think we should give chemo and then keep on follow up, and that will be a ideal thing, because once it recurs, then we can still think of doing a resurgery rather than thinking now.
I completely agree with you, sir. With that high Ki-67, I would be inclined to give some form of adjuvant for sure. But yeah, maybe offering surgery right now is probably an overkill, but just completely observing would probably, it would give me the chills in case the patient develops a recurrence later on and then regret.
Looking at the third line, are additional diagnostic tests are recommended. Can we do something with the MMRD or with the MSI high in this patient, if it is there or not? Can this help us in some decision making at this stage?
So we should do MSI anyway for all patients with colorectal cancer, because it tells us about the genetic predisposition. But it will not help here, because here there is no nodal dissection that has been done. And I would not go with Ki-67 because it's a grade 1. And again, it's not validated in colorectal. I would be guided by the nodes here. And because the patient has not actually had node, I mean, I don't know what kind of TME, maybe there are nodes. Sometimes you go back to the pathologist and find out that there are nodes. And we've seen that, they can find nodes if they look more nodes as well. So I would not have the MSI. The only thing it can tell you that if the DNA is stable, if all the 4 MLH1, MSH2 and all the 4 are intact, that means the DNA is stable and the chemotherapy is likely to provide more benefit. So because it's a DNA damaging agent, 5-FU, so it will give probably more benefit here. And one can argue about, it's a T2 tumor, whether one should go for just single agent 5-FU capecitabine versus give FOLFOX, Capox. So again, if the patient has no comorbidities, PS 0, one could just get away with 4 cycles of Capox. I'm assuming that the patient has not had optimal node dissection.
So thank you, ma'am. Just to add, the Navya recommendation in this case was that please do an MRI to look for nodal disease. Also CEA to be done. If nodal disease is present, then it will require chemoradiation followed by surgery, or else can be followed up. So it is, I think, in line with the panel recommendation here.
Yeah.
So
surgeons, the one thing I want to make is, for all surgeons, it's very important. Like I see a lot of patients with a right hemicolectomy, 2 lymph nodes removed, 3 who've had surgery in the community. It's very, very important that, maybe do the surgery with a cancer surgeon who follows the principles of cancer surgery. Because that patient may actually have stage 1 or 2 tumor, and we end up giving chemo just because they've not had adequate nodes removed. So those principles must be followed in the community.
Totally agree with you, ma'am. Just one more point, especially since you mentioned the right colon. So just like we follow the TME, total mesorectal excision for the rectum, we are following the complete mesocolic excision for the colon, because this is all respecting the embryologic planes. So this improves our lymph node yield. Of course, these concepts are very recent, and slightly senior surgeons who are more likely to do less amount of lymph node dissection, either not removing enough, or even the pathologist may not gross enough. So there are 2 aspects to it. So in the community, if someone is to find less number of lymph nodes that are there on the pathology report, the first thing would be to get back to the pathologist and discuss with him. Try to ask him or her, for more lymph nodes to be grossed, more lymph nodes to be assessed, and then take a decision based on what that discussion entails.
Absolutely.
So thank you, sir. Thank you, ma'am. And if anybody has any questions, the floor is open for the question on this case.
Naga, is this an active Assam case?
No.
Okay. You can put in chat box also the questions, actually.
You can put the questions in the chat box, or you can ask, and you can have a discussion also here.
I think we can proceed to the next case.
Yeah, we can go to the next case.
The chat, we can answer them as and when they come.
Yeah, we can have a final discussion on the question answer in the end.
Yeah.
So this is the second case, which is a metastatic rectal cancer, and I request Mr. Apurva to present the case.
Yeah. So good afternoon to all our expert panel members and all the participants. I'm presenting the second case, which is a metastatic rectal cancer. So this is the case of a 46-year-old male with stage 4, that is NET, NEN-M1 rectal cancer. Histology is adenocarcinoma. There is bilateral external iliac and retroperitoneal lymph node metastasis. Currently, the patient is treatment naive. So family history of cancer is unremarkable. Patient has an alcohol history, occasional alcohol history. He has a significant past medical history of ulcerative colitis since 2010. and has been on treatment since the same year. So the presentation starts with the complaints of diarrhea and hematochezia since October 2023. Initial examination was with colonoscopy, which showed a rectal lesion 4 centimeter from the anal verge, causing luminal narrowing and transverse colon inflammation. Procedure note says that it was a polyploid lesion in rectum, ulcerative colitis E3 disease up to proximal transverse colon, and no evidence of perianal disease. So a colonoscopic core biopsy from colon showed no evidence of malignancy. And the same colonoscopic core biopsy from rectum showed adenocarcinoma of grade 2. There was a CT abdomen pelvis done, which showed 5 to 6 into 1.5 centimeter rectosigmoid colon mural wall thickening, extension from 4 to 6 o'clock position, 7 centimeter above level of anal verge, extension to left pararectal region, 3 to 6 o'clock position thickening. There are sub-centimeter bilateral external iliac, right hypogastric retroperitoneal lymph node, multiple small pararectal, mesorectal lymph node. Largest is again sub-centimeter, 0.7 to 0.5 centimeter. D10, L3 vertebral body, right posterolateral sclerosis, extension to lamina and pedicle. Descending rectosigmoid colon, sun mucosal fat proliferation. And a radiology note says that the rectosigmoid colon wall thickening with focal exophytic extension in left pararectal region is suspicious of neoplastic pathology, and the submucosal prominent fat proliferation in the descending and rectosigmoid raises possibility of underlying inflammatory bowel disease. Subtle areas of sclerosis has been ruled out as indeterminate clinical significance. Then there was a subsequent MRI pelvis done, which showed a 5.7 into 1.4 centimeter high to mid rectum wall thickening, same 4 centimeter from anorectal junction, 7 centimeter above the anal verge, extension to left pararectal region, invasion to mesorectum at 3 to 6 o'clock position, extension to beyond the rectal wall into the mesorectal fat, involvement of mesorectal fascia is seen, few sub-centimeter bilateral external iliac retroperitoneal lymph nodes, multiple small sub-centimeter mesorectal, pararectal, pre-sacral lymph node. Largest is 0.7 into 0.5 centimeter. The mid-rectum lesion again is suspicious for malignancy, and the mesorectal fascia appears to be involved at this location, and there is evidence of EMVI. Multiple small sub-centimeter size to enlarged mesorectal, pararectal, pre-sacral lymph nodes. So the retroperitoneal lymph nodes seen are on radiology, not yet biopsied. Same with bilateral external iliac lymph nodes, which are not yet biopsied. So the stage is being considered as stage 4A, NET, NEN, M1A question mark because of the lymph nodes, non-regional lymph nodes. CA is high at 8.7, done on October 6, 2023. Chem7 profile is a normal. CBC and LFT profile is not available. ECOG is 1. Symptoms include fatigue, and a patient is planned for surgery with colostomy, and post-surgery, if required, then radiation therapy and chemotherapy has been planned. So I'll pass on the discussion to the panel members.
Thank you, Apurva. And Dr. Rakesh Kapoor, can you please, we can start from you.
Yeah, I think looking at the whole profile, Naga, one thing is, I hope I am audible.
Yes, sir.
So he is a young patient, and he is symptomatic for the rectal tumor. Also having additional thing which has come to the picture is the ulcerative colitis. So, and there is a distant nodal involvement on the CT which is there. So I will definitely like, first thing should be that we should have in this patient, a PET scan is mandatory, because that is to rule out the metastasis to any other area. Because if the disease is localized like this, then still we can have an approach of doing with a radical intent to go ahead with a neoadjuvant chemoradiation. and then followed by assessment for local surgery. But before that, I like to rule out any metastasis at other sites by doing a PET scan in this patient. So that is what I like to do. Second thing, because the high up nodes are already involved. So if you look at it at one area, it is shown that the disease has gone up to the D10 level, the nodes are there. So possibly we can think of doing, if the biopsy is with us, we should do the KRAS status and MSI status in this patient beforehand only. So that will also help us in deciding for a chemotherapy protocol, or even if we are thinking of a delayed surgery after neoadjuvant chemo radiation, we can still give 2 to 3 more cycles of chemo and decide for surgery after a gap of about 6 to 8 weeks or even 10 weeks can be good enough for this patient. So that is how I'll go looking at his age, CEA level, and the local status of the disease plus the nodal status which is already there. I don't think if the PET shows positivity in the lymph nodes and there is a high SUV value, one can still go ahead with neoadjuvant treatment in these patients.
Thank you, sir. And Dr. Shravan?
I agree with sir. A PET scan would be very much indicated in this case, especially to know the status of the lymph nodes. Although the CT does not show that they are very large nodes, they all seem to be subcentimetric nodes, but they are in locations which would probably get me more inclined to get a proper metastatic workup. I think only CT abdomen pelvis has been done. The chest has not been imaged, number one. Number two, even if they are metastatic, one message I would like to pass on to all our viewers is probably colorectal malignancies is one area where even if you find metastasis, it does not mean that the patient is a palliative patient. So you can still give a curative intent treatment. And that depends on a lot of factors, but this needs to be known, especially because other sites of GI cancers are not so. So even if the metastasis is confirmed, you can still give the patient systemic therapy and look for downstaging, and then you can probably give curative intent management in this patient. As far as the surgical aspect is concerned, since he has a E3 disease as per the Montreal classification of ulcerative colitis, which is quite an extensive disease going up to the transverse colon. So if the patient finally comes up for an evaluation for surgery, my plan would be total proctocolectomy with a ileal pouch in an anastomosis. This is, of course, in the absence of any other disease elsewhere. The liver, I don't see there is any liver disease, and the lung will need to be imaged to get an idea about that. Bhawna ma'am, any contribution from your side?
So I think I would agree with you completely. Do a CT chest. That's it. Because of a CT abdomen pelvis, MRI pelvis is good quality, that will give us the right information. All of these nodes are sub-centimeter. And for our patients in India, I think two things which stand out. For here, this is a young gentleman. Ulcerative colitis itself would lead to reactive nodes. And also tuberculosis. So, and we see that quite often in breast, in colorectum, and we can go around chasing this node and doing an FNA. But whatever way we look at it, this patient, even if it is metastatic, probably has oligometastatic disease. So we should actually treat with curative radical intent. I would, because of the CRM is involved, because of the CRM being involved, I would actually go for something like total neoadjuvant therapy here, because that itself puts the patient in a very high risk. And I think, did the patient have EMVI also on MRI?
Yeah, EMVI is also.
So all of these are, very high risk. So for rectum cancer, the topmost is EMVI, then it is mesorectal fascia or CRM. And then it is, lymph node is last actually, as far as prognostic pattern is concerned. So EMVI and CRM trump everything. So this patient should get total neoadjuvant therapy. And because he has ulcerative colitis, I would probably not go for FOLFIRINOX. what I would do is I would start with something like Folfox gently, because these patients can have terrible spurious diarrhea, and maybe do a diversion colostomy if he has symptoms which will help him, which I think that was planned, and that is being planned probably because of diversion, to divert actually. Do that so that the patient sails through chemotherapy. And I would give 12 weeks of Folfox, or maybe add irinotecan in second or third cycle. And also, I would also do MSI testing here, because if the patient has no financial constraint and is MSI high, then we have very good data that one can consider neoadjuvant immunotherapy as well. I know the number of patients was very small, but that comes into the mix. But for 95% of our patients, we have to give them chemotherapy. So I would give chemotherapy and then restage. And at the time of restaging, now Dr. Kapoor may not like this. There were two studies presented at ASCO this year, Prospect and POARC, which said, maybe selective use of radiotherapy neoadjuvantly. So, patients who don't have a complete response to chemo, you then take them for chemo radiation. But if they've had a complete response, then in this patient, probably he's a young gentleman, I would go for surgery. I would have a low threshold for, watch and wait here. I would probably prefer to go for surgery.
Frankly, the year-on-year evolution of rectal cancer management is so fast and so ever-changing. The landscape is like...
It's difficult to keep up, actually.
Yeah, seriously.
With the studies. Dr. Rakesh, yes.
In fact, what you have said, madam, I don't deny that. If it is to be done in patients who have the local disease should not be extending beyond to the muscularis, to the muscle. In this patient, if you carefully look at the CT report, the local disease is so big that it is involving almost the pararectal area. It is going to the adjacent soft tissues. There is a thickening which is present there. So I personally feel only chemotherapy may not be of help. Chemoradiation, definitely it will be. And here, one more thing just for the audience, because these days it is a trend towards short course versus long course. So everybody is thinking that we should do a short course chemotherapy because of the load on us. I still say that in this patient where there is a ulcerative colitis in the patient, one should not venture into a short course chemotherapy with a high dose of 5 gray per fraction into 5 fractions. Because once you give high dose chemotherapy, you're bound to have more complications once the surgeon explores this patient. So it will be ideal to go with a 1.8 gray per fraction long course treatment up to 50.4, or if you want, you can just want to shorten than 45 in 20, but still 50.4, 1.8 per fraction will be the 8 gray per fraction, will be an ideal regime for such type of patients who have associated IBS, who have ulcerative colitis, who have Crohn's. They should not be experimented with high dose per fraction, because they are the patients who don't do well with a high dose per fraction. That is my take on this patient, ma'am.
Dr. Rakesh, but let me just pick your brain here a little. So I agree that the patient is having quite a lot of mesorectal disease and the CRM is involved and all, and we would like to have better downstaging locally, and that's why you would probably go in for long course chemoradiation. But let us also give a thought that the patient is probably with EMVI positive, likelihood of metastasis increases. So don't you think that giving short course and getting in the chemotherapy early on in the treatment course, would that not be beneficial?
Early on chemotherapy, you give 2 cycles, as most of the people plan these days in such group of patients where there is such a heavy locally advanced disease. But he has ulcerative colitis associated with it. So once with ulcerative colitis, you give more dose per fraction, means 5 gray per fraction. So it is going to create a lot of problem for you, because you know that if you give short course, minimum period you should wait should be 8 weeks before you exploit for surgery. And in 8 weeks time, that means 2 months you are bound to have the side effects of high dose per fraction. So that is why I always vouch that those patients who have such type of comorbidity should be given standard 1.8 gray perfection, because tolerating both together, because additional chemotherapy will also enhance the BED. So that will produce another effect on the local mucosa of the rectum. It may not be feasible for the surgeon even to go ahead with a good results in the surgery. There may be fistula formation, a lot of wound adhesions, complications, multiple things will happen in such group of patients. That is what we have seen here in PGI. Many a times they call me in the OT and they show me that this has happened in the patient, because we have a full-fledged surgical oncology department. And there is a MCH surgical oncology people are there. So surgical gastro is a separate department here. So they are doing a lot of good surgeries, but they call you in the OT and ask, what is this? Please show us. So you go back to your own TPS system, you find out the isodoses again, and you find that there is a lot of condensed dose which has happened at that site. So I will not go for a high dose perfection in this patient. So that is my take.
So, thank you for your great discussion that we are having on these cases. Considering the time that limitation we have on the 4 o'clock margin, we will. I would request your inputs on some of the recent advances in rectal cancer treatment. I think instead of going for the third case, it would be good if you can add few inputs on the locally advanced rectal cancer management, and then also on the recent advances in rectal cancer management. I think that would be helpful. So, Dr. Bhawna, ma'am, can you please start?
I just wanted to highlight one point which is very important, is the MDT discussion. So every case, every patient is individual, and we have to individualize treatment. You already saw, even amongst experts, you may have disagreements. And that is important. That is very important, so that, it is for the best of the patient. And ultimately, you, after discussion, come to a consensus as to what is best for the patient. I think the recent advance for me that is very important is neoadjuvant, total neoadjuvant therapy. Now, whether you give chemo followed by long course, or whether you give a short course radiotherapy followed by chemo. So for this young gentleman, I feel chemo followed by long course radiotherapy, followed by surgery would be the ideal pattern. And MSI testing has kind of, I've had some amazing responses in patients who are MSI high. And not only for genetic predisposition, but they have a dramatic response to chemotherapy. And patients who are MSI high, which is like 5% of our rectal cancer patients, they actually do not respond well to chemotherapy. All my chemo patients, who are signet ring, again, signet ring also does not respond very well to chemotherapy. And during chemo, they may develop peritoneal disease. So to, look at these things as well, because if they are MSI high, I feel sometimes even a low dose of immunotherapy is quite helpful in these patients, especially if you've had given chemotherapy and you've not been able to downstage them. And so I know that, chemotherapy is expensive, but in head and neck cancer, TMH has led the world actually, in giving a very low dose of nivolumab, 40 milligram, which costs about 40,000 rupees. So instead of, 4 lakhs. So if you have a patient, you really need downstaging, MSI high, chemo has not worked. I have had patients at the end of long course chemoradiotherapy where we've not been able to downstage adequately. Then, one should think laterally and give them maybe immunotherapy. So I think for me, that is the biggest advance, and avoiding radiotherapy. Because, things like proctitis, sexual dysfunction, these are problems which happen 10 years later, 15 years later. So if we can somehow avoid radiotherapy and also maybe avoid surgery in some patients, which is like, 20% of patients. It is not going to happen in majority of patients, but watch and wait strategy, please do it in discussion, in collaboration with an amazing radiologist, surgeon, radiation oncologist, and a gastroenterologist, because, These patients need to have MRI pelvis every 3 months, CA monitoring, and also endoscopy. So these are my thoughts. I'd now love to hear what Dr. Rakesh and Dr. Shravan think.
Yeah, I think as Madam has said, there is so much of development which has happened in the management of, I'd say, not only rectal cancer, cancers as such. So it is more and more becoming a personalized way of handling the patients by using different type of drugs, immunotherapy drugs, as well as targeted agents. So keeping in pace with that on the similar grounds, there are a lot of developments which have happened on the radiation side also. So what fears are there in the mind, I just want, because Shravan is here, we are giving now neoadjuvant chemoradiation to operable, potentially operable pancreatic cancers in PGI. And they are doing very well. The surgeons are very happy with that. See, one thing is very important. As you have individualized targeted markers, you have IHC markers, and you have immunotherapy for patients. Similarly, for the any cancer for that matter, even for rectal cancer, now the contouring guidelines are individualized. So you can create CTVs as per your choice, depending upon the patient's PET CT or the CT images which you have taken. So there is no need to go the same way. You have to include the lymph nodes up to the beyond the bifurcation of the iliacs, or you have to go lower down up to the anal verge. So one can make tailor-made CTVs depending upon whether it is a mid-rectal disease, lower rectal disease, or it's a high up rectal disease. That means just short of rectosigmoid, or you are going beyond rectosigmoid. So these type of tailor-made CTVs will definitely decrease the normal tissues which are coming into the field. And then the dose which we are giving is very important. So whatever dose we are giving now, it is not going to produce proctitis, because the tolerance of this region, I'm talking of the long-term complication. Acute rectal reactions, acute proctitis is bound to develop, and that happens also. And rather, we vouch for that grade 1, grade 2 reaction should happen, the acute reaction. The late-term complications does not happen if you have planned very well and you have segregated, or the avoidance structures have been delineated once you are contouring the tumor. So you can delineate the small bowel area if it is coming inside, and you can also take care of the colonic areas if they come or fall into the pelvis. So prone position planning with the help of the belly board, this is standard now. So you are doing all those things. So complications are not that important. You do a full bladder protocol. So bladder pushes the intestine up, and that does not come every time you vouch for the same position to be matched with your online onboard CBCT. So these things are possible now. So this is something which is doing good. One thing which Madam Bhawna has already touched, that is immunotherapy. I am also a great proponent. I feel that we should think of radioimmunotherapy, because it is producing wonderful results in liver as well as in lung patients. We are doing SBRT protocols in both, and we are very happy with those protocols in PGI.
Thank you, sir. So I see the journey of oncology as being supra-radical to tailor-made, and as both of my panelists elaborated on this, because to give you an example, one of the best examples is breast cancer surgery. So you had a supra-radical mastectomy coming down to breast conservation. So, and I think this is all pervasive, because this is happening in almost all subsites. There are for example, rectal cancer. So there used to be a time where the extensive nature of surgery was, hello, am I there?
Yeah, you're audible.
You are audible, sir. Please continue.
Yeah. So I was getting at that we are tailor-making our treatment protocols depending on various factors. So I see oncology being more personalized and individualized, as Madam mentioned. That is my first point. My second point is about MDTs. So the multidisciplinary team management is something which we need to be very, very focused on, because when I was in TMH, we compared our outcomes of pre-MDT era and the post-MDT era, and the survival almost doubled. So an MDT is something where you have the surgeon, the medical oncologist, the radiation oncologist, the pathologist, the radiologist, and even a stoma care nurse probably, who can give a wholesome treatment approach to the patient, because ultimately the patient comes as one, and the treatment also should be given as a whole. So you cannot have bits and pieces of here and there, and that's my take on the MDT. As far as TNT is concerned, a lot of discussion going on in recent years. It's actually very interesting and very it's a good thing that's happening in rectal cancer management, because it addresses quite a lot of issues that we have seen, where patients don't end up getting systemic therapy, and they used to get only loco-regional treatment in the form of chemo, radiation, and surgery. But now when you're giving all of that radiation and chemotherapy upfront before the surgery, then the compliance rates are high. So only one word about that is, since in Indian patients, we see a lot of young patients who are signet rings and mucinous tumors who are not very responsive to the chemotherapy, and would probably benefit from getting out the tumor as early as possible than putting them on a longer duration of neoadjuvant therapy. So again, there needs to be some evaluation there as far as our patient cohort is concerned. So although the TNT concept has come from the West, we need to evaluate it in our own patients and see how it works out. Having said that, TNT has has shown very good DFS rates and PAT complete response rates. I would like to see some long-term survival benefits as far as TNT is concerned. But yes, that is, TNT is here to stay, and even not only in rectal cancer, we see TNT protocols in pancreatic cancer also, as Dr. Rakesh mentioned. The other thing is immunotherapy for a very small subset of rectal cancers today has shown very promising results. And I'm sure in the coming years, we are going to find more targets, which is again bringing us back to the individualized therapy concept. So we are likely to have more number of such decision-making targets, and that's how we are going to plan the treatment further, I think. Yeah, that's about it. That's about my take on how we are going.
Thank you, sir. And I thank all the panelists for their views. Now the floor is open for the question answer session. If anybody has any question, you can either put it in the chat box or you can ask it here.
I would just like to say, thank Navya from the bottom of my heart. I mean, I've been working with you since 2012 and since the journey started. And I think you're doing a great job in democratizing education to far and wide corners of the globe, not just India now. So thank you for doing this.
Thank you for your support, ma'am. With the support of great people like you only, we have been able to deliver and achieve all these things. Without your support, we cannot do all this.
Yeah. I want to ask Dr. Shravan one thing, So all this, we get a lot of opinions on Navya, the robot lap and in rectum. Do you think it really makes a difference?
Yes, definitely, because I have my experience predominantly has been open surgeries till now. Very recently, I started doing laparoscopic surgeries. My biggest problem when I was doing open surgeries was reaching inside a pelvis, which is so narrow, especially in males. Because that compromises my clearance. So there are times where I am a little lost when I go lower down in the rectum. With the laparoscopy coming in, the view is very magnified, and I can see the nerves. I can see where my dissection plane is. I can see what is the level of my mesorectal dissection and all those things. So that really helps improve the surgical ergonomics, and that translates into better oncologic outcomes. As far as robotic is concerned, so the jury is out whether laparoscopy or robotic, because robotic obviously escalates the cost compared to laparoscopic surgery, but robotic still has its place, because in, for example, lateral pelvic lymph node dissection, doing it laparoscopically is a nightmare, frankly, because there are too many structures in the lateral pelvic space. You have the ureter, you have the nerves, you have internal iliac branches. There are too many structures that it can damage. Doing it robotically is actually a little easier, because you are in control of 3 arms by yourself. So ergonomically, yes, the robot still has a role. Whether robot is irreplaceable, I would have my reservations because I have seen Dr. Seklani manage even complex cases laparoscopically with great expertise. So the learning curve is there, and as long as you can negotiate the learning curve, I think the modality hardly matters.
Great, thank you.
So one question from my end, like I was just going through the guidelines and other things. I found that there are no rectal cancer specific guidelines from the National Cancer Gradient NCG guidelines. So is there anything that you recommend for the Indian oncologist to follow in the absence of such a guideline? Like, is there anything that
Naga, we have just done with all the most members of NCG represented. We've just made the ISMPO guidelines, and we've actually done a consensus, and we've had a member of ESMO and NCCN on it as well. We had Dr. Gina Brown, who's like the queen of MRIs globally, and Dr. Aparna Parikh from NCCN. So those guidelines should come out, I mean, the accepted, revised, peer-reviewed, and should come out in the next couple of months, I hope. And we've kind of sort of Indianized them as well a little bit. And we've involved surgeons, radiation oncologists, everybody, you know, about 45 people from the country.
Great, ma'am. I think
no, that's very required, madam, because Indian cohort is a really a special cohort when you compare it with the West, and we need to have guidelines.
Specific guidelines.
More specific. Yeah, I agree.
Great.
And any other questions from the audience?
Good evening, Bhawna ma'am. I'm Dr. Venkat from Tejpur
Dr.
Cancer
Venkat,
Center.
I was just telling them about Tejpur. How are you?
I am good, ma'am. Thank you. Ma'am, thanks for mentioning that the guidelines that will definitely be useful for most of us. And thanks for involving me as well.
Yeah.
Ma'am, in Assam, there are some of the hotspots for rectal cancer, just like gallbladder cancer, where there is very excessive consumption of red meat, like Karbi Anglong. This is one of the districts in Assam. And also in Nagaland, where my colleagues working there. Are there any special recommendations for such areas with a very high incident areas for the family members, apart from MSI screening as well? Any other special recommendation from an Indian perspective for such a hotspots particularly?
So we've actually just applied for a grant. I can't talk about it, but I would suggest, you know, doing and also applying to ICMR from the hotspot areas for stool FIT screening, fecal immunochemical test. And I found, I mean, if you WhatsApp me later, I will send it to you. I found something which is very cost effective. It's like 100 rupees or something. And if you buy it in bulk, it could be cheaper as well. So I would suggest in these high prevalence areas doing a FIT test. And because you need only one stool sample there, you don't need 6 stool samples as you do with the old GAIAC test. And at least once a year for people above 30. I mean, the UK has brought the age to 45, but we are seeing so many young, the breast, cervix and head and neck, the Indian government is doing from 30 years. I feel we are seeing so many young people with colorectal cancer. And, you know, it's 100 rupees a year. It's nothing. Or maybe even if you buy it, it'll be 50 rupees. So it's worth doing it. And if it is positive, then you do a colonoscopy. So do a risk stratified, and we've actually developed a questionnaire also. So maybe you could do a questionnaire-based stratification and then do the fit in average, in high-risk people. If you want to do it like, you know, do it in a village completely or a district.
I mean, what's the sensitivity?
Pardon?
The sensitivity, FIT?
Is about 85%.
Thank you, ma'am. And second question is, ma'am, in many of the areas in the ACCF center, we see patients presenting with a very delayed presentation, going to physicians, surgeons, and then presenting in a very poor performance status as such. Although the cancer is not metastatic, some of them are in PS2, PS3. So how to go about with the neoadjuvant therapy in that setting, ma'am? Because in PS3 to give even in the complete dose of chemotherapy at full doses, it's quite challenging in them. So Is there any alternative strategy you follow, ma'am, when you encounter PS3 or something like that?
So I think, and of course, the albumin is low sometimes in these patients, and I would aggressive nutrition. And also their PS is low because because of the disease, not being able to sit, not being able to eat, not being in pain. I have seen if you give a 50% Folfox also, immediate symptom relief happens in some of them. They are able to sit on the tire that they bring with them, most of them. And then down the line, depending on the staging scan, you then do the long course radiation and everything. But to begin with, that one course of Folfox, K-Pox, I find very difficult to give. Or you give K-Pox the 2-weekly regimen, but also again 50 to 75% of the dose. Because I think these patients are treatment naive, and some of them respond very beautifully. And but of course the risk of recurrence is very high, but at least you can give immediate symptom relief. And I saw so many patients like that in Tata Hospital when I was there. 18-year-olds, 20-year-olds coming with a fungating tumor. So even the radiation oncologist would say, the field is too wide, it's too much, better give some chemo, shorten it a little bit. And so I would actually go for dose modified Folfox, which is kind of gentler. And within 2 cycles, you will know how they're doing.
Yes, ma'am. Thank you so much. We actually do the same, ma'am, but I usually go for K-Pox and gradually escalate it, ma'am, because as it is a daycare center, I do not have opportunity to give Folfox. We do not have evening.
Also fine. I normally then start with 1 tablet twice a day for 10 days. And, tiny 50 per meter square of oxali, and then slowly escalate it.
Yes, ma'am. I am doing the same, but I just want to be sure that if it is the right strategy or not. Yes, ma'am. Thank you.
It's great.
Any other questions? I think with this we have.
Yeah, good evening, everyone. I'm Bhawna from Navya. Sir, I have a question for Dr. Shravan. Dr. Shravan, sir, could you please explain when does a patient require permanent colostomy or temporary colostomy?
So the decision between a temporary and a permanent colostomy is based on the tumor characteristics. So if I have a patient with a very low rectal mass involving the anal sphincter complex, then the patient is likely to get an abdominoperineal resection. So in the situation where the patient has an APR planned, then the patient needs to be counseled for a permanent colostomy, because that is usually in the left side of the abdomen. It's a permanent sigmoid colostomy. There are times when we would do a temporary colostomy, usually the transverse colon. This is for patients who are eventually going to get a low anterior resection. That is a sphincter saving procedure where we don't close the anal sphincter. And that is where a temporary colostomy in the form of a transverse colon is brought out. There are also times where we do ileostomy, as is our standard practice in Tata Memorial. So any patient who has a sphincter saving procedure, depending on the tumor characteristics, depending on the intraoperative parameters, we decide whether the patient gets a diversion ileostomy or not. The diversion ileostomies and the colostomies are usually temporary. So once the patient gets better from the surgery, completes the chemotherapy, we are likely to close the stoma. The only situation where we don't close the stoma is when the patient gets a sphincter exterminating surgery, like a abdominoperineal resection. That is where it's going to be permanent.
Thank you, sir. In the interest of time, we would like to close the discussions here. Any queries you have, you may please mail it across to me. My email ID is there in the invitation that you got. We will get back to the experts and get the responses for your questions. And with this, we will conclude the webinar here. And I thank Dr. Bhawna Sirohi, Dr. Rakesh Kapoor, and Dr. Shravan Nadkarni, the team of ACCF, and all the participants for their active participation and bringing up such a beautiful discussion on the rectal cancer management. I think the interaction has been very helpful for all the participants, and we would like to have some more webinars of this kind, wherein we have more interactions and less of presentations. I think that would be something that we look forward to do more and more often, and of course with all your support. And I thank you all, and
Thank you so much.
thank you.
Thank you, Navya. Especially special thanks to Dr. Rakesh and Dr. Bhawna ma'am. It's been a personal privilege and honor to be part of this.
No, it was a pleasure talking to you, actually. And you should
Despite
follow
all the
me on
tight
Twitter.
schedule, Despite the tight schedule, Dr. Bhawna Sirohi, Dr. Rakesh, and Dr. Shravan Nadkarni have made it to this webinar. You know, they told me the constraint they had, and still they have made it to the
busy schedule apart. There's a India New Zealand semi-final also going on, so there's quite a lot of people to get back to that possibly.
That's, you put me under more stress. Thank you.
Yeah. We don't have interest now for all those things, but there are other things which are waiting for that.
Yes.
Thank you so much. Thank you, ma'am.
Thank you so much.
Thank you.
Thank you. Bye. Bye.